Hello students. Students, today we will discuss about the NEET PG 2023 Pediatrics recall based questions. So as these are recall based questions, the statements of the questions may vary, options may vary, but the main intention is to discuss the questions so that we can discuss all the important points about the questions that has come in the exam. Okay. So coming to the question number 1, this is the question from the Inborn errors of metabolism topic. In this exam, around 5 questions appear from this topic. In all our lectures, we have already talked like this topic is very important, inborn error of metabolism. So 5 questions this time from this topic. Now we are discussing these questions one by one. Okay. So number 1 question, a child presented in OPD with muscular weakness and developmental delay. Okay, so developmental delay present, muscular weakness present. On examination, very important, cherry red spots are seen and there is no organomegaly. So these are the most important clues that are present in the question, cherry red spot and there is no organomegaly. The child might be suffering from which of the following conditions? Okay, and the options are Niemann-Pick disease, von Gogh disease, Gaucher's disease and Tay-Sachs disease. Okay. So students, out of these 4 options, this Niemann-Pick disease is a lysosomal storage disorder, Gaucher's is a lysosomal storage disorder and Tay-Sachs is a lysosomal storage disorder. Von Gogh disease is a glycogen storage disorder. And you all know that the cherry red spots are characteristically seen in 4 important lysosomal storage disorder. And these disorders are GM1 gangliosidosis, GM2 gangliosidosis, Farber disease and Niemann-Pick disease. The mnemonic to remember it is go for Niemann-Pick, because we all always remember that Niemann-Pick is a lysosomal storage disorder and it has cherry red spot. We always remember this. But the 3 important points that we always forget is GM1 gangliosidosis also have cherry red spot, GM2 gangliosidosis, Tay-Sachs has cherry red spot, Farber's disease and then Niemann-Pick disease. So go G, 2 G's, 4 Farber and Niemann-Pick. Okay, so these diseases have cherry red spot. Now, in the options that are given to us, the Niemann-Pick has cherry red spot and Tay-Sachs have cherry red spot. Okay, Gaucher's don't have cherry red spot. And von Gogh is a glycogen storage disorder, no cherry red spot is seen in it. Out of these 2 options now, when we talk about the organomegaly, no organomegaly is present. We all know in Niemann-Pick organomegaly is characteristically seen, hepatosplenomegaly is seen. Okay, it is the Tay-Sachs disease in which there is no organomegaly seen. So cherry red spot with no organomegaly is seen in Tay-Sachs disease. So answer for this question is option D, Tay-Sachs disease. Also one important point about Tay-Sachs disease is these children have exaggerated startle reflex. Sometimes this can also ask in the question that these children have exaggerated startle reflex, mental retardation, developmental delay is there, they suffer from seizures and ultimately these children mostly die at the age of 2 to 3 years of age. Okay. So this is about the question number 1. Now coming to next question. A child presented with complaints of bony pain and anemia. Okay. And the bone marrow aspiration was done, whose picture is shown here. So what are you able to see in this picture? So can you see this cell, the cytoplasm of this cell? Similarly, so the cytoplasm of this cell shows crumpled paper appearance. Okay, so wrinkled or crumpled paper appearance of the cytoplasm of the cell is characteristically seen in Gaucher cells, you all know. Okay, so bone marrow aspirate, Gaucher cells are present. So we are dealing with in this case the Gaucher's disease. Now in the question what has been asked, which enzyme deficiency is seen in this case? So in Gaucher's disease, which enzyme deficiency is present? The options are hexosaminidase, glucose 6-phosphatase, glucocerebrosidase and alpha galactosidase. So you all know that in the Gaucher's disease, the enzyme deficient is glucocerebrosidase. Okay, so this is such a clear-cut question, such a easy question, and you all know that in the Gaucher's disease, there are 3 types are there. That is the type 1, 2 and 3. Okay, so in the type 1, characteristically seen in the adults, it's a non-neuronopathic form. Okay, so non-neuronopathic form means that nervous system involvement is less. They have characteristically presence of pancytopenia. So pancytopenia is constituted by, you all know, anemia, thrombocytopenia, leukopenia. Then they have hepatosplenomegaly. And number 3rd, because of the involvement of the reticuloendothelial system, so they have skeletal involvement in the form of bony pains. And in the question we have already been given bony pains and anemia is present. Okay. In the type 2, that is mostly infantile variety. Infantile, it's a neuronopathic form. Okay. And type 3, that is a subacute neuronopathic form or the juvenile variety. So 3 types of Gaucher's disease is present. And next important point in the X-ray finding, X-ray mein what we see is aerial flask deformity. Aerial flask deformity is present in the long bones. Okay. So this is something that you all should know about the Gaucher's disease. And the enzyme deficiency is glucocerebrosidase. Hexosaminidase deficiency, students, is seen in, yes, it is seen in GM2 gangliosidosis. Okay. GM2 gangliosidosis is of 2 types, Tay-Sachs disease and Sandhoff's disease. In the Tay-Sachs disease, there is deficiency of enzyme hexosaminidase A, and in the Sandhoff disease, there is deficiency of enzyme hexosaminidase B. Glucose 6-phosphatase deficiency is seen in von Gogh disease. Okay, and alpha galactosidase deficiency is seen in Fabry disease. Okay, so this is seen in Fabry disease. Now, another important point that you all should remember is the Fabry disease is only lysosomal storage disease which have X-linked recessive inheritance. Rest of the lysosomal storage disorders have autosomal recessive inheritance. Okay, so see, a lot number of important questions we have covered from this only topic. And the Gaucher's disease is always examiner's favorite topic. You all must remember this topic. Okay, next. A 1-year-old girl presented with recurrent episodes of fasting hypoglycemia. So as soon as we talk about the system fasting hypoglycemia, we should always think about the glycogen storage disorders. Okay. Next, the liver biopsy reveals no or minimal glycogen deposits. Which enzyme deficiency is associated with this condition? And the options are glucose 6-phosphate, branching enzyme, glycogen synthase and debranching enzyme. Okay. So as I talk about fasting hypoglycemia, always think about the glycogen storage disorders. Now, what are the various glycogen storage disorders and the enzyme defect? Number first is the von Gogh disease. Glucose 6-phosphatase deficiency is there. Okay. And because of this deficiency, there is hepatomegaly and renomegaly because of the glycogen deposits are there. And in this question, there is characteristically no or minimal glycogen deposits on liver biopsy. Okay. So this can't be the answer. Next, number 2 is the Pompe disease. Pompe disease, there is deficiency of the lysosomal acid alpha-1,4-glucosidase or acid maltase. So this is the disease which involves mainly muscles. Okay. So there is cardiac involvement mainly there, and there is the muscular weakness, proximal muscular weakness is there. Liver involvement is not there. Okay. Number 3, Cory's disease or limit dextrinosis. There is deficiency of debranching enzyme. Okay. So students, you should remember that number 1 and number 3, these two disease have similar kind of presentation. So Cories have presentations like von Gich, but somewhat lesser than von Gich, but similar manifestations are there. Okay. So in this disease also, there will be glycogen deposits in the liver. Okay. Number 4th is Anderson disease, in which there is deficiency of enzyme, that is the branching enzyme. And this is the disease which is associated with liver cirrhosis. Okay. Next, 5th is McArdle's disease. McArdle's, there is deficiency of enzyme myophosphorylase. So, this is involved with the muscle glycogenolysis, not the liver. So, no involvement of the liver. HERS, number 6 is HERS. There is deficiency of enzyme liver phosphorylase. 7th is Tori disease, in which there is deficiency of phosphofructokinase enzyme. Again, this is related to the muscle glycogenolysis. Then this 9th, there is deficiency of enzyme phosphorylase kinase, and then coming to 0, there is deficiency of enzyme glycogen synthase. So if there is deficiency of enzyme glycogen synthase, so no glycogen is able to form, and this is the only glycogen storage disorder in which the liver biopsy shows no or minimal glycogen deposits. So students, it's a rare disorder, but this is something an unusual question, so you should always keep an eye on such questions. Okay. So no or minimal glycogen deposits with episodes of fasting hypoglycemia is seen in type 0 glycogen storage disorder, which is due to enzyme deficiency glycogen synthase. Okay, so answer is C for this question. Now coming to next question. A 6-year-old boy presented with complaints of muscle cramps during exertion. Laboratory investigations revealed hypoglycemia and low lactate levels the child might be suffering from. And the options are McArdle's disease, Gaucher's disease, Duchenne's muscular dystrophy, spinal muscular atrophy. Students, the options that are given in this question, I am not sure about these two options. Okay, so but inputs that I have got from the children. So these two options were there, but I am not sure about these two options. Okay. So let's talk about muscular cramps during exertion is present, hypoglycemia and low lactate level is present. Okay. So again, the question directly shows that we are talking about a glycogen storage disorder. Now, the glycogen storage disorders that are associated with the muscle glycogenolysis are the data associated with muscle cramps. Okay. There is exercise intolerance. Okay. And in extreme cases, what happens is there is rhabdomyolysis. And which leads to myoglobinuria. So in questions, sometimes they can ask you a red color urine or a burgundy colored urine is present. This can also be given in the history. Okay. So these are the characteristic features that are seen in the disorders of muscle glycogenolysis. Data number 5, glycogen storage disorder number 5 and number 7. And the second disorder that is associated with the cardiac problems, that is hypertrophic cardiomyopathy and proximal muscle weakness, is number 2, that is the Pompe's disease. Okay. And you all know that number 5 is McArdle's disease. So the answer to this question is McArdle's disease. Gaucher's disease, we have just discussed about it. So no such features are seen in the patients of Gaucher's disease. And Duchenne's muscular dystrophy, the presentation is entirely different. It's not about the muscular cramps during exertion. There is muscular weakness. And at the age of 6 years, there will be a profound muscular weakness. Okay. So these are not the answers. Answer is A. Now, another question from Inborn errors of metabolism, and a very, very easy and direct question. A black colored urine is seen in which of the following conditions? Okay. And the options are phenylketonuria, Alkaptonuria, maple syrup urine disease or homocystinemia. Okay. So, black colored urine is seen in, we all know the answer is Alkaptonuria. So, in Alkaptonuria, students, there is deficiency of enzyme homogentisate dioxygenase. This enzyme is deficient, due to which there is accumulation of homogentisic acid. So, this is a disorder of phenylalanine metabolism pathway. Because of the accumulation of homogentisic acid, it leads to polymerization of this homogentisic acid when it comes in the contact with the oxygen. Due to oxidation, there is polymerization of homogentisic acid, which leads to blackening of the color of the urine on standing. And this is the only finding that are seen in this patient in the childhood, in the infancy. Okay. So, mother complains that the diaper of the child is grey or the black colored. Okay. And in the adults, what we see is ochronosis. What is ochronosis? That is blackening. Because of these deposits in the ear cartilage or the nose, there is blackening of these areas. There will be arthritis or there can be cardiac problems. Okay. Now, in the phenylketonuria, the characteristic urine finding is there is mousy odor. Okay. So, mousy odor is there in phenylketonuria. In the maple syrup urine disease, the characteristic odor that we seen in these patients is a maple syrup type odor or a caramel type, or what we call as the burnt sugar odor. Okay. And next, in the homocystinemia, there is characteristically marphonoid features are present and there is intellectual disability seen in these patients. Okay. So, blackening of urine is seen in Alkaptonuria. Okay. Now, coming to the next question. So, a preterm with respiratory distress has ground glass opacity on X-ray chest. What is the cause? So, in the question you have the preterm. The preterm has respiratory distress and X-ray has ground glass opacity. So, the most common cause of this is respiratory distress syndrome or hyaline membrane disease. Okay. And you all know that this respiratory distress syndrome is due to the deficiency of surfactant that is produced by the type 2 pneumocytes. Okay. Now, in the options we have been given with the sphingomyelin, lecithin, phosphatidylethanolamine and cholesterol. So, these are the basic constituents of the surfactant only, but the majority of the constituent, the major constituent of surfactant is this phosphatidylcholine. The other name for the same is lecithin. Okay. So, the lecithin constitutes 60 to 70% of the surfactant. Okay. So, that is why the answer for this question will be, if we have to choose one option, the answer will be B, lecithin. RDS is caused by the deficiency of lecithin. Okay. Now, coming to next question. A preterm newborn is having respiratory distress at birth. Again, what is the most probable reason? Again, this question is just similar to the previous question. Okay. So, a preterm with respiratory distress, the most common cause is respiratory distress syndrome, I already told you, or the hyaline membrane disease due to deficiency of the surfactant. Now, what is the role of the surfactant? Okay. So, the options are, there will be decreased surface tension, there will be increased lung compliance. Okay. Number second is, there is increased surface tension and there will be low lung compliance. Third, decreased surface tension and low lung compliance, and fourth is increased surface tension and increased lung compliance. So, we all know what is the work of surfactant. So, if this is the alveoli, okay, so what the surfactant do is, it decreases the surface tension of this alveoli so that it keeps on opening. There is no collapse of the alveoli at the time of expiration. Okay. So, it decreases the surface tension and it increases the compliance of the lung basically. So, but in the case when there is decreased surfactant, so there will be opposite. What will be there? There will be increased surface tension and there will be decreased lung compliance. Okay. So, there will be increased surface tension and there will be low lung compliance. So, answer to this question will be B. Okay. So, the main phenomena is that is because of the surfactant deficiency. So, the work that the surfactant does, that will be the opposite will be the answer. Okay. Next, best sign of adequate infant growth in an infant with 2.8 kgs birth weight. So, you know 2.8 kgs is the average Indian baby birth weight. Okay. So, best sign of adequate infant growth they have asked about, and the options are: length increases by 25 centimeters in first year of life. So, you know that the length at birth we normally say it's 50 centimeter and at 1 year of age it becomes 75 centimeters. Okay. So, there is increase of around 25 centimeters in first year of life. So, maximum growth spurt after birth is in the first year of life and second growth spurt is in the pubertal phase. Okay, in the puberty. Okay. So, length increases by 25 centimeters in first year of life is the correct option. Next option, weight under 25th percentile and length under 75th percentile. So, when we talk about the best sign of adequate infant growth, weight under 25th percentile is never the best sign. The child can be normal, it's not like the child have some problem, but it is not the best sign. Okay. Next, anterior fontanelle closes by 6 months. No, you all know that anterior fontanelle closes by 12 to 18 months of age. Okay. Next, the weight gain of 300 grams per month till 1 year of age, not till 1 year of age. So, in first 3 months of life, the weight gain is around 30 grams per day. Okay. Then in 4 to 6 months, it is 20 grams per day. Okay. Then in 7 to 9 months, it is around 15 grams per day. Then it gets 12 grams per day in next 3 months. So, it is not the same in first year of life. So, D option is wrong. So, out of the 4 options, the answer A is correct. Okay. Now, coming to next question. A 2 months old baby presented with the following X-ray findings, and condition given is swelling since birth is present. So, students, on this X-ray, can you make out this swelling that is present over the parietal region? Okay. So, and the options that are given are caput succedaneum, subglial hematoma, encephalocele and cephal hematoma. So, firstly, let's see the age of the child. It's 2 months old. Okay, so in a 2 months old, caput succedaneum is something that is not present. So, caput succedaneum, we all know the caput, that is a subcutaneous swelling. Okay, so caput succedaneum is a subcutaneous swelling, that is a boggy swelling, is a diffuse swelling that crosses the midline and it is seen at birth and it resolves in next 2 to 3 days, not associated with any of the complications. Okay, this is something that is there in caput succedaneum, and as the age of the baby is 2 months, so this can't be the answer. Next, coming to the subglial hematoma. So, students, some important point about subglial hematoma. So, this subglial hemorrhage or hematoma, that is seen in the aponeurosis of the skull. Okay, beneath the aponeurosis is present in the subglial area, and the most common causes in the cases of like vacuum delivery or in the children with the hemophilia. The most common cause for the subglial hemorrhage is this, and it's also a diffuse swelling that crosses the midline, and the swelling gradually increases in size. But the most important is it generally resolves by 2 to 3 weeks of life. The most common complications that are seen in subglial hemorrhage is because there is a hemorrhage, a lot amount of hemorrhage is there. So, these children can present with the shock. Okay, anemia and even jaundice can be seen. Mortality rate is as high as 20% in these children. So, a prompt recognition is very important in these cases. but again it's a large boggy swelling that crosses the midline, and it generally resolves by 2 to 3 weeks of age. And again the child's age is 2 months, and this is a localized swelling, so it can't be subglial hematoma. Okay. Third, encephalocele, you all know it's a bony defect. Okay, and most common area is occiput, so this also can't be the answer. Fourth, cephal hematoma. Now, in 2 months of age, sometimes the cephal hematoma can persist. So, because book writes, it resolves in around 4 to 8 weeks of life. Okay, so it can persist up to 2 months of age, and we all know that cephal hematoma, it's present between the periosteum and the skull bone, and it's a localized swelling that does not cross the sutures. Okay, so looking at all the options, the best possible option for this answer is cephal hematoma, option number D. Okay, now next question. A 3-month-old infant presented to OPD with complaints of yellowish discoloration of skin and clay colored stools. Age is 3 months. Investigations revealed conjugated hyperbilirubinemia, and the biopsy revealed a periductular proliferation. Very, very important point. What is the most probable diagnosis? So, in a question, children, they have already told about the conjugated hyperbilirubinemia is present. So, you all know about the bilirubin metabolism pathway. Whenever there is breakdown of the RBCs, so the hemoglobin is breakdown into heme plus globin. Okay. This globin goes into the amino acid pool, and this heme part is converted into biliverdin by heme oxygenase. This biliverdin is converted into bilirubin by biliverdin reductase enzyme. But this biliverdin that is formed in the reticuloendothelial system, it's a unconjugated bilirubin. The unconjugated bilirubin is lipid soluble, water insoluble. So, it can easily cross the blood-brain barrier. So, this is the one responsible for connectiveness. Okay. Now, this unconjugated bilirubin goes into the liver for the conjugation, and after the conjugation, this conjugated bilirubin is released into the duct, through the bile duct into the gut. Okay. Now, there are two fate for this conjugated bilirubin. This conjugated bilirubin, in the presence of the bowel bacteria that are present, it breaks down into urobilinogen and stercobilinogen. The stercobilinogen is the component that gives the stool the yellow color, and urobilinogen through the kidney, it goes inside the urine giving yellow color to our urine. Okay. Now, whenever there is conjugated hyperbilirubinemia, it is mainly because of the obstruction. There is obstruction to this pathway, and when there is obstruction to pathway, so what happens is this stercobilinogen is not able to form, giving a clay color to the stools. Okay, and there will be increased formation of urobilinogen, giving a dark yellow color to the urine. So, conjugated hyperbilirubinemia is there. Okay. Now, when we talk about the causes of the conjugated hyperbilirubinemia in a newborn, so conjugated hyperbilirubinemia is because of two causes. Okay. So, there can be hepatic or extrahepatic causes. Okay. So, hepatic is there is some problem with the liver. Now, the problem can be in the liver parenchyma. Okay. Or there can be problem with the liver, the ducts that are present, intrahepatic ducts. Okay. So, in the parenchyma, there can be metabolic disorders, there can be infections, the torch group of infections. Okay. Or there can be an entity that is known as the neonatal hepatitis. Okay. Idiopathic neonatal hepatitis. In the ductal causes, we can talk about the intrahepatic ductal paucity syndromes. Okay. And in the extrahepatic causes, the two important causes are the choledochal cyst and the biliary atresia. Choledochal cyst and the biliary atresia. Okay. Now the options that are given here are, you have biliary atresia, Crigler-Najjar syndrome, Dubin-Johnson syndrome and Rotor syndrome. Okay. So out of these 4 options, when we talk about the conjugated hyperbilirubinemia, these are only seen in the cases of the biliary atresia, Dubin-Johnson syndrome and Rotor syndrome. Okay. Crigler-Najjar syndrome have unconjugated hyperbilirubinemia. So this can't be the answer. Okay. And the severe manifestations seen in 3 months of age with the liver biopsy characteristically showing the periductular proliferation is a feature of a biliary atresia. So this is something that you should always remember, that in biliary atresia, the liver biopsy findings are bile ductular proliferation, presence of the bile ducts, portal or perilobular edema fibrosis with basic hepatic lobular architecture is intact. Okay, so this is the findings that we are able to see in the questions. So the answer to this question is biliary atresia. Now next question, identify the vitamin deficiency in a child with this bony defect. Very easy question again, children. Okay, so the bony defects is seen. You can easily see that this is a genu varum type deformity. Okay, so varum is these kind of knees, valgum is knock knees. Okay, so genu varum deformity is present. Now the vitamin deficiency, vitamin K, you all know that vitamin K is not associated with any bony defect. It is associated with the coagulation disorders. Okay, vitamin C, scurvy. Again, such kind of bony defects are not seen in scurvy. Vitamin D, rickets. So this is the condition that is seen in the rickets. So other important bony condition that can be seen is wind swept deformity. So in wind swept deformity is also seen as vitamin D deficiency, in which both the limbs are, one is in the varum and one is the valgum position. Okay, and vitamin A, you know, ocular problems are there, night blindness is there. Okay, so these kind of problems is there. So the answer to this question is vitamin D. Now next question, a 3-year-old infant with history of raw egg ingestion has following here findings. Which of the following vitamin deficiencies seen? Vitamin A, zinc, biotin and vitamin C. So as the question suggests, there is history of raw egg ingestion. So again a very direct question, students. Raw egg contains avidin. We all know this. Avidin inhibits the absorption of biotin. Okay, and because of this deficiency of the biotin, there is presence of this dermatitis and alopecia, scaly dermatitis and alopecia is there. Okay, so answer to this C is C, biotin. Okay, vitamin A deficiency we all know with the ocular findings. Zinc, there is periorificial rash is present. Okay, and acrodermatitis like picture is present. Then in vitamin C, scurvy. So the answer to this question is C, biotin. Next, a child with scurvy presented with the gum bleeding. What is the cause for the same? Again very easy, students. Scurvy, vitamin C. Okay, options are defect in the collagen synthesis, low calcium, inhibition of the clotting factors and impaired keratinization of epithelium. So very direct answer, that is defect in the collagen synthesis in scurvy. Okay, so low calcium is because of the vitamin D, inhibition of clotting factors vitamin K and impaired epithelialization of epithelium is because of the vitamin A. Okay, so in scurvy there is defect in the collagen synthesis A. Next question, a baby presented with the petechiae, jaundice, hepatosplenomegaly, periventricular calcifications and sensory neural hearing loss. Urine microscopy shows owl eye inclusion bodies the child might be suffering from. So a very important point is there is periventricular calcifications. Okay, and you all know that periventricular calcifications is seen in which of the infections? So the options are congenital cytomegalovirus infection, syphilis, toxoplasmosis and rubella. Now the periventricular calcifications is characteristically seen in the congenital CMV infection, cytomegalovirus infection. The triad that is seen in CMV is CMC valor. Okay, CMC is the mnemonic. So there is chorioretinitis. M4 there is microcephaly. And then C4 there is calcifications, and characteristically there are periventricular calcifications. Okay. In toxoplasmosis also we see calcifications, but the calcifications are basically the diffuse calcifications are seen in toxoplasmosis. In rubella, the triad that is characteristically seen is, the mnemonic is CCD. Okay, so C4 there is congenital heart disease, the most common being patent ductus arteriosus. Next C4 cataract, and then D4 there is deafness. Okay, so these are the important features. When we talk about calcifications, the two important other viruses that you need to remember is, number first is the HIV virus. In HIV, the most important calcification is basal ganglia calcification. Okay, and the recent update, that is the Zika virus. The Zika virus calcifications are mainly subcortical calcifications. Okay, so a very easy question has been asked in the exam, periventricular calcifications and data seen in congenital cytomegalovirus infections. Okay. Now, next important question, neonate presented with patent ductus arteriosus, deafness and cataract. Again a easy one, very easy question. The classical triad is given, patent ductus arteriosus, deafness and cataract. Just in the previous question we discussed that this is a triad of congenital rubella syndrome. So CCD, congenital heart disease present, that is the patent ductus arteriosus, C4 cataract and D4 deafness is present. Okay. In toxoplasmosis, diffuse calcifications are present. Congenital cytomegalovirus infections, CMC. CMV virus has CMC. This is the mnemonic. Okay. So chorioretinitis, microcephaly and calcifications that are periventricular calcifications. And herpes simplex virus, these can have skin lesions, eye lesions or encephalitis type picture can be there. Now coming to the next question. A child presented with fever, coryza and conjunctivitis. Again very direct question, Koplik spots are noticed on examination. Students, such direct questions are been asked in this NEET PG, so there is like nothing can be done, like it's very easy. Okay, so fever, coryza, conjunctivitis, you know, is the classical triad of measles and along with the Koplik spots, so nothing can be the answer else than measles. Okay, in the rubella, characteristically that we see is 4 shimmer spots. Okay, so a question can be asked about the 4 shimmer spots are seen in rubella infection. In mumps, parotitis is seen, and in varicella you have initially macular lesions which then turns into the papules and then vesicles, dewdrop appearance is present, centripetal in location, pleomorphic rash. So these are the features of the varicella. Okay, now in some important other points are Naya gamma spots. You know, once the question was asked about the Naya gamma spot. So Naya gamma spots are seen in which infection? The 6th disease. Okay, so 6th disease, Naya gamma spots is seen. Okay, so in this question, Koplik spots, which is very direct question, seen in measles. The Koplik spots are seen basically in the lower first and in the buccal mucosa opposite to the lower first and second molar. Onset of illness within 2 to 3 days. Okay, so coming to the next question. A 10 years old child presented with abdominal pain and vomiting. On examination, there is tachypnea and severe dehydration is present. investigation reveals a pH of 7.01, which the normal pH is 7.4. So it's a acidic pH. Okay. The bicarb levels are 7 millimoles per liter. Again, bicarb levels are very low. The normal is 22 to 28. So it's a metabolic acidosis like condition. The urinary glucose is 3 plus. Urinary glucose is increased and the random blood glucose levels are 550 mg per deciliter. So from the question, now you are able to make out, students, that we are dealing with a condition of hyperglycemia, okay, with metabolic acidosis. So the only condition that comes in mind after doing this is DKA, that is diabetic ketoacidosis. So we are dealing with the condition of diabetic ketoacidosis in a 10 years old child, and the characteristic features are also same, that there is abdominal pain, vomiting, there is dehydration, there is, because of the Kussmaul's respiration, there is tachypnea is there. Now the question has been asked about the management of this condition. Which of the following statements are true about the management of this child? Okay, and the options that are given are initial airways, breathing, circulation, resuscitation with 20 ml per kg of fluid and insulin started after 1 hour. B is ABC resuscitation with 10 ml per kg of the fluid and insulin started after 1 hour. C is ABC resuscitation with 20 ml per kg of fluid and insulin started immediately. And fourth is resuscitation with 10 ml per kg of the fluid and start of the insulin immediately. Okay. So when we talk about the DKA, students, there is a classification of the diabetic ketoacidosis, okay, in which on it's mild, moderate and severe. So the normal pH is 7.35 to 45. The normal bicarb levels is 20 to 28. Okay, in mild, bicarb levels 16 to 20 and the pH from 7.25 to 7.35. And in this, the patient will be clinically oriented but fatigue. In the moderate patients, the bicarb levels are 10 to 15 with a pH of 7.15 to 7.25. Kussmaul's respiration is present but the child is arousable. And in the severe conditions, the bicarb will be less than 10, as in this patient the bicarb is 7. The pH will be less than 7.15, as in this patient the pH is 7.01. There is Kussmaul's respiration. The child is sleepy with altered sensorium. Okay. So the most important point in the management of the diabetic ketoacidosis is first is the fluid. So fluid therapy is very important. If in the question there is mentioning of severe dehydration is present, it means the child is in shock, severely dehydrated child. So in this case, we have to always resuscitate the child with the fluid of 20 ml per kg of body weight. That is the protocol of shock. If this severe dehydration word was not given or the shock word was not given in the question, then we would have given the fluid at the rate of 10 ml per kg. Okay. And the second important point you need to remember in the cases of DKA is, firstly we will do the fluid resuscitation and insulin is started only after 1 hour of the fluid resuscitation, not immediately along with the fluid resuscitation. Okay. So these two options in which insulin is started immediately is wrong. Insulin has always to be started after 1 hour after fluid resuscitation, and as the child in this condition has severe dehydration, so the fluid that we will give to the child is 20 ml per kg of the fluid. So students, you are the better judge, you are the best judge who have given the exam. So if the severe dehydration was given in the exam, A will be the answer, and if severe dehydration is not given, the child is not in shock, then the answer will be B. Okay. So the options are accordingly. Now coming to next question. A child is brought to pediatric OPD with fever and stridor. An X-ray shows the following picture. So can you make out, students, this characteristically steeple sign that is present in the X-ray? So you all know that steeple sign is characteristically seen in acute laryngotracheobronchitis. It's a very easy question. Okay, so steeple sign is present, there is stridor is present, it's acute laryngotracheobronchitis, or the other name for the same is croup. In acute epiglottitis, what you see is thumb sign. Okay, and laryngomalacia and foreign body has different picture, entirely different picture. Okay, so the answer to this question is D. Very, very easy question. Next, a child presented with fast breathing and was diagnosed as pneumonia. What will be the drug of choice? So according to the IMNCI protocol, a child who presented with fast breathing will be labeled as pneumonia. Okay, so fast breathing, oblique chest indrawing will be pneumonia, and these patients will be sent home on antibiotic. Okay, and the antibiotic that is given according to IMNCI protocol is amoxicillin. So it is the drug of choice. Oral antibiotic will be given to this patient. If this patient would have any of the danger signs or the SpO2 levels will be low, then the child would have been labeled as very severe disease. Okay, and in this case we need a injectable antibiotics and immediate admission. Okay, so answer to this question is A, amoxicillin. Next, sweat chloride levels are tested in which of the following conditions? Again, a very, very direct question. You all know the options are cystic fibrosis, osteogenesis imperfecta, antitrypsin deficiency, and primary ciliary dyskinesia. Again, students, I am not sure about these options, but the cystic fibrosis was definitely given, and the answer is cystic fibrosis. We all know the sweat chloride levels are done in cystic fibrosis. It's an autosomal recessive condition. Okay, next question. A 7-year-old boy presented with complaints of recurrent bleeding. Past history reveals bony pains. No mucosal bleeding is seen. Okay, which coagulation factor deficiency is seen? So, bony pains with recurrent episodes of bleeding. So, the most common coagulation defect in these patients is factor 8 and 9, that is the hemophilia. Okay, and bony pain is because of the hemarthrosis. So, the answer is very direct, that is answer is B. Next, which of the vaccines is recommended for a 10-year-old child according to the National Immunization Schedule of India? And the options are typhoid, TD, chickenpox and rabies. Okay. So, students, according to the National Immunization Schedule of India, the typhoid vaccine is given at the age of 2 years of age, and not in all the areas, but in Delhi it's 2 years of age. Typhoid vaccine is given. Okay. At 10 years of age, previously tetanus vaccine was recommended, but now the TD is recommended, that is tetanus and diphtheria. The chickenpox vaccine is not there in National Immunization Schedule, but according to the Indian Academy of Pediatric schedule, the minimal age for chickenpox vaccine is 15 months and the next dose to be given after the 3 months. Okay. And also the rabies is not a part of National Immunization Schedule. It is given as a post-exposure prophylaxis. Okay, so answer this question is B. That's all about the discussion of the recall based questions. Thank you, students.